Mr. Chairman, ladies and gentlemen, first of all, I would like to thank you, organizers, for inviting me to participate in the Paris Hepatology Conference. This is my disclosure. Due to the nature of HDV infection, it may seem logical to assume that prevalence of HDV is closely related to the prevalence of HBV. However, this is not a universal rule. The prevalence of HDV is endemic and highly variable with several hotspots like Mongolia. On the contrary, there are several endemic pockets like Japan, Korea, or Indonesia, where the prevalence of HBV is high moderate, but the prevalence of HDV is unexpectedly low. In the countries with a low prevalence of HBV and very low prevalence of HDV, migration from endemic regions during the last 2 decades has resulted in a rapid increase of HDV prevalence. To understand the nature of variability in HDV prevalence and its trends, it's useful to examine data on epidemiology of HDV in some countries in details. Recently, a large population study was conducted in Mongolia, which included more than 4,000 serum samples from rural and urban areas. The study showed that the prevalence of HDV in the population was 4.8%. However, when taking into account the fact that HBV prevalence was 4.3%, it found that the prevalence of HDV in HBs antigen-positive population was more than 50%. Another study conducted on serum samples from Ulaanbaatar city population confirmed these findings, reporting 68.6% prevalence of HDV in S antigen-positive subject. Interestingly, the study also found an association with syphilis, with the prevalence of both HBV and HDV doubling in comparison to syphilis-negative samples. This suggests that the sexual transmission is one of the major drivers of incidence of HDV in Mongolia. Uzbekistan is a country located in Central Asian region, not far from Mongolia. The HBV prevalence in Uzbekistan is moderate, and the prevalence of HDV is around 8%. However, a study of serotics in the main national center over 3 consecutive years showed that HDV is leading cause of liver cirrhosis. We will discuss the difference in prevalence of HDV between serotic and general population later, as it's an extremely important point in understanding the epidemiology of HDV. But in this case, the most interesting facts about this serotic population are that they are young, and the major risk factors for infection were blood transfusions and surgery, rather than intravenous drug addiction or sexual routes of transmissions. Let's shift our focus to Canada, a typical country with low prevalence of HBV and a high but controlled migration rate. It would be logical to expect that the major source of HDV cases would be immigrants from endemic areas. However, the Canada Hep B network study showed that HDV-positive patients were more likely to be male born in Canada and of white or Afro-American ethnicity compared to Asian patients. Additionally, HDV-positive patients were more likely to engage in high-risk activities such as injection or intranasal drug use or high-risk sexual contacts compared to patients infected with only HBV. One possible explanation for this phenomena may be different transmission of HDV in different populations. In endemic pockets, the main route of transmission is co-infection, which is associated with low number of persistent infections, resulting in a low prevalence of HDV in liver disease patients. In populations where the superinfection scenario is more common, the majority of patients develop chronic infection, which is reflected in a high number of advanced liver disease associated with HDV. Therefore, in a high moderate prevalence of HBV infection does not necessarily mean the high prevalence of HDV and vice versa. Even in a low HBV prevalence environment like in Canada, HDV can be the cause of substantial number of advanced liver disease cases. According to this hypothesis, it would be quite difficult to estimate the number of HDV patients considering only serological data from blood donors. Several meta-analyses have attempted to estimate the number of HDV patients worldwide. According to one of these meta-analyses, the estimated number of HDV patients globally is 72.4 million people. However, some analyses for individual countries have yielded unusual results. For example, it predicts 0 HDV patients in France, that it's not true in reality. Another meta-analysis used a more sophisticated approach. They considered the quantity and quality of available data for each country and used known HDV risk factors in each country to develop additional country-specific methods to estimate HDV prevalence at the population level. In these 16 countries, a refined literature review yielded an overall population level weighted anti-HDV prevalence of 5.2% in the people with HBs antigen. But when the authors adjusted these findings for geographical distribution, disease stage, and special populations, HDV prevalence fell to 2.2%, and they further adjusted the country-level anti-HDV prevalence for HDV RNA positivity. The overall anti-HDV rate fell to 1.5%, and the total estimated number of patients was 161,000 patients only. Why are the results of meta-analysis so widely different? The answer is hidden in the data sets used for estimation. In the same countries, the prevalence of HDV differs between blood donors or healthy population in HBs antigen screening cohorts, tertiary centers, and serotics, with the highest prevalence found in the latter group. However, in many countries, there are no equal quality data sets for all of this subpopulation of patients. Meta-analysis use as much data as they can find and then combines them, resulting in a fantastically high or fantastically low estimated number of HDV patients. This map, developed by Mario Risetto and co-workers, is beautiful because it uses endemically specific colors rather than country-specific colors. This is important for many countries. For example, in most parts of Russia, the prevalence of HDV is low, but there are endemic spots here in Yakutia, Tiva, and Altai regions where the prevalence is high. However, these regions together account for less than 1% of country population, so the burden of the disease at the country level is considered low. It seems like a good idea to evaluate the burden of the disease by the prevalence of HDV in serotics rather than in blood donors. For many areas of yellow color at this map, HDV is vanishing disease, but migration from endemic areas produces the waves on new cases. For instance, in Italy, HDV infection has decreased over the decades and mainly affects older individuals with an advanced disease, reflecting a survival effect. Conversely, people born abroad are 6 times more likely to be anti-HDV positive, and there is an increasing trend over time. Similar trends have been observed in Spain, where has been decreasing HDV prevalence among those born in Spain over time, but the increasing number of new cases among immigrants during the last decade. Interesting approach for evaluating HDV incidence and its trends was performed by American group. They used open governmental databases from 17 countries that accumulate data on diagnosed disease to calculate the ratio of HDV diagnosis per 100,000 HBV diagnoses. They identified structural breaks in the incidence of HDV diagnosis in 20 years period that can be classified in 4 different clusters using mathematical analysis. Interestingly, this type of analysis revealed typically endemic pockets like Taiwan and Macau in the cluster 1 with no change in HDV-HBV ratio over 20 years. In contrast, typical yellow zone of the Mario Risetto map, these are Northern European countries, were found in cluster 4 with a very low HDV-HBV ratio during the first 15 years of 21st century, followed by a sharp increase during the migration from endemic area. A few words about the molecular epidemiology of HDV. To date, 8 different genotypes have been found worldwide, with genotype 1 being the dominant and present everywhere, while other genotypes are regionally specific. There are some speculations about the role of genotypes in the clinical course of the disease or an oncogenic potency, but this has remained unproven. Unfortunately, screening rate for HDV and HBV positive population, even in those who are in high-risk group, is unacceptably low. In this study from US Tertiary Center, patients of Asian origin were tested for HDV more often than other groups. It was surprising, as the studies have shown, that in North America, white or Afro-American people who inject drugs are the most affected risk group for HDV. By using reflex testing for HDV, the rate of positive diagnosis can increase up to 5 times. Interestingly, 60% of those who were diagnosed through the reflex testing and were HDV RNA positive did not have any known risk factor for infection. This indicates that screening only in high-risk groups is suboptimal, and that reflex testing could potentially aid in identifying undiagnosed cases. In conclusion, ladies and gentlemen, global prevalence of HDV is unknown, and estimated number of patients varies from hundreds of thousands to the tens of millions. In many countries, HDV infection vanishes in local population due to total vaccination against HBV for many years, but majority of new cases related to migration from endemic areas. Structural breaks in the incidence of HDV during the last 20 years can be related to the change of the major mode of transmission and migration patterns. Reflex testing for HDV should be universally accepted as it dramatically increases the number of HDV cases revealed and provide us a reliable data about the HDV prevalence, but its cost efficacy in all populations need to be proved. Thank you for your attention, ladies and gentlemen.
Good afternoon, everyone. First of all, I'd like to thank the organizing committee, especially my friend Patrick Macelan, for this kind of invitation. In the next few minutes, we are talking about delta hepatitis treatment with interferon. Delta hepatitis was first described in 1977. This is a serious disease, a progressive disease, and can be treated as soon as possible. But unfortunately, we don't have good regimens, good treatment regimens for this severe disease. Delta hepatitis is largely underestimated. 20 years ago, it was considered a vanishing disease, and now it is considered a spreading disease because we are find out Delta hepatitis in many countries, in many areas. Besides that, Delta hepatitis has many different genotypes that can cause different diseases. So the diversity in clinical presentation and clinical aspect of the disease is another problem that we have to face before deciding treating these patients with interferon. We cannot compare, for example, the Delta hepatitis that we see in Europe and the US with the Delta hepatitis that we see in Amazonia. They are completely different diseases. But the guidelines put together apple, pears, and oranges. This is the task of the guidelines, is to facilitate the decision making. And interferon is is recommended in all guidelines, including Brazilian guideline. But we know that we are treating different patients with different backgrounds with the same regimens. Maybe it's not the best strategy. Let's see our results. Firstly, when interferon was investigated, it is superestimated as a good treatment because we had in-house HDV RNA, not sensible, but later we discovered that the interferon is not a good treatment, but it's the only treatment that we have so far. The best studies and the more elegant studies, more robust studies showed that the sustained virological response is less than 20% with interferon. And it is because the long-term follow-up is disappointing in terms of sustained virological response. It was clearly shown by the elegant study, 10 years ago, conducted by the Hanover group. PEG interferon, what we know so far, we know that the recommendation is PEG interferon for 48 weeks. The sustained virological response is less than 20%. ADBS loss, which is the best marker for ADV cure, is less than 10%. Prolonged treatment for more than 48 weeks, beyond 48 weeks, has no advantage, proved so far. PEG interferon plus NUGs, no advantage, except in some conditions such as high HBV DNA viral load. HDV RNA at week 24 seems to be a predictor of response, but it's not enough to be used in clinical practice because many patients with no HDV RNA reduction can reach response later. Ribavirin and other antiviral treatment has no proven role so far. This is our main challenge, especially in some areas such as Brazil, where both viruses replicate at the same time. We use interferon and add nuts. It is also recommended by ASLD, but we don't have clear results that show the pertinence of this strategy. But in Brazil, in non-controlled studies, even in patients with advanced fibrosis, it seems to be the best strategy. And we do this in Amazonia region. There are many predictors of progression of disease, such as low albumin, age, elevated GGT, etc. But one predictor of disease progression is no previous interferon treatment. It means that interferon, regardless the sustained virologic response, may play a role in reducing the disease progression, especially reducing fibrosis. And also, when interferon is associated with ALT normalization, it seems to be a strong marker of reduced disease progression. So it brings a dilemma for us. Also, we have now non-invasive fibrosis marker that must be used in the clinical practice for delta hepatitis, as it has been used for hepatitis B and hepatitis C, but it's not still clear how to use these tools to decide treatment or to define subgroups of patients who should be treated and patients who should not be treated. So, PEG interferon in different profiles is a big challenge. We use interferon in patients with autoimmune phenomena. Is it appropriate? We have some patients with large splenomegaly with preserved liver function. These patients can be treated with interferon. Symptomatic and asymptomatic patients should be considered as for treatment. Ethnicity should be taken in consideration. Naive and experienced patients, the same thing. Younger and older patients. So there are many questions to be answered regarding interferon response, interferon treatment in delta hepatitis. Current recommendations, interferon for 48 weeks. No evidence to go beyond 48 weeks. In patients with high HDV DNA viral load, NUGs can be considered. And there is no other drugs up to now that is considered of importance in the treatment of delta hepatitis, except in the new drugs that will be discussed later in this section. On the other hand, you have many gaps and many questions to be answered. For example, if ALT normalized during interferon treatment, but the HDV DNA is still positive, what we do? We change for another interferon and keep for a long time. How long? Patients with autoimmune phenomena, can you use interferon without any concern? Role of HDV genotypes matters. Liver stiffness can be used for deciding treatment in this patient and define subgroups of treatment, which is the dominant virus, and depending on the dominant virus, can we change the treatment strategy with NUGs and interferon? We have different profiles of clinical profiles of patients, and should we offer the same treatment for all of them? We have different ethnicities. Some ethnicity seems to be more tolerant to interferon, and seems to have better response, but we treat with the same regimens. All these questions must be answered, but it's very difficult in the scenario of delta hepatitis in the world nowadays. So in near future, it is already the reality. There are new drugs that we evaluate in combination with interferon, and will be discussed in this section. Thank you very much. And once more, it's a big pleasure to be here talking about this neglected disease. Thank you.
Okay, thank you very much, and everybody listening to this interesting symposium. Hi, Mario. Hi, Tariq. My task has been to introduce to you some data on the new drugs for hepatitis D virus infection. This is where I'm right now, sitting at Hanover Medical School, quite green city. And at this stage already, I want to invite you to the second Delta Q meeting, which will take place here in the nice green city of Hanover and to the beginning of October. These are my potential disclosures, including companies developing drugs against hepatitis B and D. So I should target novel drugs for hepatitis D, but why? Raimundo Prana just recently showed you some data on pegylated interferon. He showed to you the limited efficacy and that there are side effects and contraindication, but also for bulevirtide, which will be covered by Tarek Asselah. We have many questions: how long to treat? We don't know the optimal dose for all patients. Not all patients respond, even though the majority does respond. We need sub-Q injections. We have bile acid elevations. We have drug-drug interactions, which needs to be considered, and we have no data in decompensated patients. These are all questions we will address during the discussion. But let me briefly summarize the data for this entry inhibitor bulevirtide targeting NTCP. This is a phase 2 study which has been published in January in Lancet ID. We have seen this data quite some time. There's a linear decline during treatment, and this trial, 24 weeks of treatment were given, and the majority of patients obviously relapsed after the short-term treatment. But we have to keep in mind there may be a subgroup of patients, small number, which maintains response off treatment. These were, in this case, 6 patients overall in this trial, but this will be interesting to see whether this number can be increased with longer treatment. This translates this decline in viral load to normalization of liver enzymes in roughly 40% of patients here. I have to highlight that the kinetics of ALT normalizations are biphasic with bulevirtide treatment, with many patients responding in the first 4 weeks of treatment, and then there's a slower decline in the long term. And we have discussed frequently that even though HDV RNA declines, even though ALT is improving, there is no change in HBs antigen in patients receiving bulevirtide monotherapy. In the phase 3 trial, which is currently in revision as a full publication, we showed this combined endpoint 2-log HDV RNA decline and biochemical normalization, which occurred in the approved dose in 45% of patients in this trial. And it's important to note that this efficacy in terms of virological reduction, here 2-log HDV RNA decline, was independent from a variety of baseline factors. So even patients with liver cirrhosis responded very well, and also, let's say, baseline viral load or ALT levels were no negative response factors. If you would combine this with interferon, there's data from a phase 2 study that there's an on-treatment synergistic effect. So these are the 2 groups which have received both interferon and bulevirtide. However, off treatment, this response was only maintained if patients in addition had also an HBs antigen loss. There were off treatment patient responses maintained, but again, this was only the case if S antigen also declined, and S antigen declined only in patients with interferon in the 2 milligram and 5 milligram arms. You can see here that some patients had the decline, which was sustained, and these were the guys maintaining HDV RNA response. If this was not the case, and there are patients not showing S antigen decline, then off-treatment HDV RNA responses were usually not durable. What's about safety of bulevirtide? It's important to note that there were no AEs leading to withdrawal of bulevirtide in the phase 3 trials. So a drug that was very well tolerated. There were some patients reporting pruritus, as you can see here. But it's important to note that this pruritus was not linked to elevated bile salts in these patients. So there might be a different mechanism. Bile salts per se did not lead to itching in these patients. Obviously, you have local site reactions, injection site reactions as patients receive the sub-Q injection. And by the mode of action, as to be expected, there was a dose-dependent increase of bile salts, total bile salts, in all trials that used bulevirtide. This was not linked to obvious clinical evident AEs, but long-term monitoring is required. We just recently published that these baseline bile salt levels, so before treatment, but not bile acid increases during treatment of hepatitis D, were associated with a subsequent HDV RNA decline, an observation which we may discuss later. So the big question obviously is long-term cure possible. Pietro Lambertico just published one case from Italy in January, where a patient was treated for 144 weeks, and 1 year after the end of treatment, biopsies were taken. No delta was detected in these patients, and this is very important. So this patient suggests that a long-term response may be possible. However, there's also a case from Austria that has been published where the patient has been stopped here after 130 weeks of treatment, and a late relapse was observed in this patient. So, and at this stage, we apply maintenance treatment for bulevirtide, and if some patients may be stopped, this needs to be answered in the ongoing trials. Few data on lonafanib, where a large phase 3 trial has been initiated based on a smaller case series published from Turkey, where a dose of 50 milligram bulevirtide in combination with ritonavir was investigated with more pronounced declines when the drug was combined to interferon alpha. We have a press release where the phase 3 data have been presented. So lonafanib boosted with ritonavir alone in combination with interferon versus interferon or placebo. And these were the virological declines. So 14% of the patients receiving lonafanib and ritonavir achieved a 2-log decline. This was the case in 32% receiving the combination treatment, but also in 36% receiving interferon alone. And the question is, why was this the case? We observed here an HDV RNA decline early during treatment, which was more pronounced in the combination group, but the lonafanib virological responses were lost during the second half of the treatment. And obviously, the question is, what is the mechanism behind this? So it will be interesting to discuss this data during an upcoming conference. Lambda is also being tested, and there has been a trial performed in Pakistan and in Israel and some patients in New Zealand. The trial has just been presented in hepatology, and where interferon lambda, which is supposed to have less systemic side effects, where 5 patients in a high-dose group achieved a dural virological response, which was the case in 3 out of 19 patients in the lower lambda group. And this drug is currently being tested in a larger phase 3 trial. And lastly, nucleic acid polymers. We have seen data from 12 patients in Moldavia for quite some time, which showed a pronounced HDV RNA decline and also S antigen decline when these nucleic acid polymers were given alone and interferon was then added. Quite interesting data. We have seen additional case reports presented during recent meetings, also in patients not responding to bulevirtide. This is just one example where you can see here where HDV RNA showed a nice decline when this drug was given alone. We need obviously controlled systematic trials, and we may discuss also with Mark who presented some of this data during recent meetings. So this is my last slide. I think that for most patients and in most countries, PEG interferon is still the standard of treatment of hepatitis D for most patients. Bulevirtide is approved by EMA. I mentioned some of these questions, which we may also discuss after Tariq's presentation. Additional new treatments are in clinical development. but we definitely needs personalized management approaches. I'm 100% sure that in future there will be not one size fits all treatment like we have for hepatitis C. We will have some patients where we still use interferon. There may be some patients where bulevirtide alone is reasonable. And this is something which we need to address. We need to define this. And we invite you to discuss these questions during the second Delta Q meeting in Hanover, taking place October 5 to 6. And obviously, we will also have there plenty of time to drink coffee, which should be good also for our Delta patients. Thank you very much.
Dear colleagues, ladies and gentlemen, I'm pleased to present in this session on therapeutic advance, bulevirtide in real life. These are my disclosures. I am a professor of medicine at University of Paris, Hôpital Beaujon, and I'm the chief of the viral hepatitis research at INSERM. And I have many clinical trials ongoing, mainly on Hep B and Delta. But also I have to report these disclosures. I have some colleagues, Algerian colleagues. We won twice the World Champion Cup and we won the African Cup with the Algerian team. These are my disclosures. So to start with the quotation, the good physician treats the disease. The great physician treats the patient who has the disease. William Osler. So this is the agenda today. A short introduction, hepatitis Delta in France, bulevirtide, a very important result, the 48-week integrated safety data. I think it's important to share this data. Bulevirtide in real life in France, Italy, Germany, and I apologize that I could not report all the real life data, but a selection. And then a conclusion. Professor Vasily Sakov showed you the prevalence of Delta with many new data. However, we don't know really how many patients are infected worldwide because the lack of strong studies and the lack of availability of the test worldwide. But we know there are some countries with high prevalence and others with lower prevalence. We need more epidemiological study, more availability of the HDV RNA tests. In France, there has been a cohort, the Deltavir study, involving many sites. And you can see that there was around 6,000 to 8,000 patients with Delta infection. And what is interesting in France is that there's a patient diversity, but also a genotype diversity. The main genotype is genotype 1, but we have also some rare genotypes, 5, 6, 7, 8 from West Africa. And so I think it's very important because in the studies, we will need to include patients' diversity, but also to have all genotype to confirm that the treatments, the future treatments, have pan-genotypic efficacy. This is the genotype distribution in France. You see genotype 1 is the dominant, and we have other genotypes. And we have been involved in many studies for Delta, and I think it's very important for genotype and patient diversity. It has been also reported that the patient has a severity, a serious outcome. You can see in this study, the percentage of patients with cirrhosis, decompensated cirrhosis, hepatocellular carcinoma, and death or liver transplantation. Professor Raimundo Prana showed you the results of pegylated interference. And you can see that around 20% of patients has RNA undetectable 24 weeks after the end of follow-up. But it has been shown also that there's late relapse. We should avoid the term of sustained virological response used in Hep C because there's late relapse and we have to follow all the life the patients. And also interferon, although not approved, is recommended by many guidance, ISOL, SLD, apazals. However, there's many side effects. There's many drugs in development with entry inhibitors, bulevirtide, which has been conditionally approved in Europe, prenylation inhibitors, lonafarnib, HBS secretion inhibitors, and we have also interferon lambda and other drugs And there's a very large HBV cure program. And if we stop HBs productions, we may also interfere with Delta replication. So I think it's important also to achieve the HBV cure program. Let's move to this important 48-week integrated safety data. You can see it includes phase 2 and 3 trials for chronic hepatitis delta, the MIR 203, 204, and 301. And very interestingly, there is a control group, bulevirtide 2 mg and 10 mg, and PEG interferon alpha. You see the characteristics of the patient, mean age, 40 years old, young people, cirrhosis, very frequent, advanced disease, compensated cirrhosis, of course. And in the safety summary, for the 2 mg bulevirtide in monotherapy or the 10 mg, there was 0 patients, 0 adverse events leading to discontinuations. And the most common adverse events in bulevirtide arms were injection site reactions. They were in the majority mild and manageable. So no safety concerns with these treatments. It's reassuring data of the safety profile of bulevirtide in a large pool of patients and longer overall exposure, with also 10 mg in patients with compensated cirrhosis. Injection site reactions are not a major issue for most patients. Tolerability is generally good, compliance is good. We need educational support regarding reconstitution administration techniques for the subcutaneous bulevirtide. Now, real-life data. Bulevirtide in France, that was conditional approval in July 2020. So we start to treat several years ago. Prescription is from the hospitals, public or private. It's a hepatologist, infectious disease, or internal medicine specialist who can prescribe. And it could be delivered from the pharmacy, from the hospital, public or private. So you see, we already report the first patient we treated. It was published in 2021 with, you can see in blue, the HDV RNA decrease, in green, the ALT decrease. And this patient has a decrease in virological and biochemical response with now the follow-up. And one patient, because of the COVID pandemic, was blocked in his country, so he stopped treatments and there was a relapse. So it's why we recommend also to maintain ongoing treatments. This is the French multi-center early access program that they do. Eligibility criteria was compensated cirrhosis or severe fibrosis F3 or F2 with increased ALT. It is a multi-center, non-randomized, open-label, observational study. You can see the baseline characteristics. So the doctors was free to treat with bulevirtide 2 mg alone or in combination with PEG interferon. And you can see that 50% were treated with bulevirtide monotherapy, 50% with the combinations. So in France, there was a large use of interferon, as in Italy and Germany, because the doctors know interferon with the treatment of Hep B and Delta. The mean age was 40 years old, cirrhosis 60% of the patients, but it was eligibility criteria, bridging fibrosis or cirrhosis. And you can see high viral load, so active disease. You see the results at 2 years of bulevirtide. So you can see HDV RNA undetectable around half of the patients, biochemical response, transaminase normalization, 60%, and finally, a virological response, decrease of 2 log, 70% of the patients, and the combined response of decrease of 2 log and ALT normalization, around 50% of the patients. So it's very similar to trials. It's an ongoing study. We have to be very careful with interpretations. It seems that bulevirtide per PEG provides minimal, no benefit over bulevirtide in the long term. Still insufficient data for futility rules. And just to recall you that in the MIR 204 study at week 24, early, there was a synergistic efficacy of PEG plus bulevirtide. But whether this is maintained or not, I think we will see in the follow-up studies. This is the Italian study, the real life, 12 weeks of bulevirtide in patients with compensated cirrhosis. You can see age, 52 years old, patient with hypertension, esophageal varices, and also active disease, HDV RNA high. And you can see very similar response. Around 75% of the patient in blue had a decrease more than 2 log, 40% of the patient HDV RNA undetectable. Biochemical response was also high with 80% of the patients. So this data confirmed from prospective clinical trials, extension to week 72 was effective and safe, no new safety issues, and we need more studies. You can see the summary of real world for France, Italy, Germany. So age around 40 years old, a high percentage of patients with advanced disease cirrhosis and with active disease with high HDV RNA. And finally, we need also to revisit the endpoints and new option for treatment of chronic delta. We need to see improvement of decreased risk of cirrhosis, decompensation, or HCC. Finally, dear colleagues, ladies and gentlemen, HDV might be underestimated. HDV increased the risk of cirrhosis. Previous treatment recommendation was interferon, it remains interferon, but we have bulevirtide, first European conditionally approved drug to treat HDV, with a good antiviral efficacy and a favorable safety profile, and there's many drugs in development. Thank you for your attention. We will start the roundtable discussion, and while waiting for questions from the attendees, we will start with the first lecture to Professor Vasily Sakov and also to Mario. What are the most important messages according finally to epidemiology? What should we be aware regarding Delta epidemiology? Professor Isakov, and then Mario for commenting.
Yes, thank you for the question, Tariq. I think that the main problem with HDV is that we do not have the equal set of the data from the different subgroups of the population. And it is because it's quite difficult to interpret the results of meta-analysis. Because meta-analysis take any data they like or they can afford and mix them. And this data is not equal. And sometimes this meta-analysis produced a very high number of patients or a very low number of patients. The second point is that the prevalence of antibodies in blood donors does not reflect the real burden of the disease to the society. Because, again, the endemic type of the disease. Some countries, they're in the pockets, some countries, they're in the hotspots, and in some countries, there we have the mixed situation. The third problem, I think, may be they said that we were assured that in those countries in which the vaccination against HBV already introduced like 20 years ago, the disease is vanishing, and the only driver is the migration. But I showed an example of Canada, and I can get some example other countries in which the migration is very well controlled. But in any case, we can see the increase of the incidence of the HDV because this is the behavior. There's a vast increase of the intravenous drug abusing, not in the immigrant, but in the local population. And I think that this is a three major problem for the epidemiology. Of course, the reflex testing can give us more wide data about the general population, but it's not a main task when we try to evaluate the burden of the disease for the society. And I think that nowadays we have no better approach than to look at the changes in the proportion of HDV in the etiology of liver cirrhosis, like in Uzbekistan, that it was endemic. But it reflects the real burden of the disease for the country or for the society or for the ethnic group, I think. This is, I think, these 4 points for epidemiology.
Vasily, I appreciate listening to you that you focus on some regions. It was most important to speak of regions than on countries. And I saw in the map that it was like the Silk Road with Pakistan, with Afghanistan. So maybe Mario, could you comment about this Silk Road and some high prevalence in some regions?
Yes.
Like,
I think that the epidemiology is quite simple if you look from the standpoint of vaccination. High-income countries started vaccination in 1990. Most of the 30 years, 40 years people are now vaccinated against B, and they cannot get Delta. So if you look at the map, all high-income countries are free of Delta, except from what comes from outside countries where there's still Delta, means immigrants. Second, vaccination is not only in high-income countries, but it started also in many middle to high-income countries and low to middle-income countries. So this is making it, is declining, is forcing a declining of Delta. Therefore, if you take data 10 years ago, they are different now from 10 years ago. This has to be considered in evaluation of epidemiology. But I mean, it's very simple. Delta is no longer a problem in high-income countries' domestic population. It is, as said by Vasily, in immigrants. But then in Iran, in Turkey, in many other countries, the prevalence of Delta is diminishing because they are enforcing year after year vaccination. And this has to be considered in any epidemiological evaluation. Third, and final, there is a big difference between the patient or the individual at the blood bank with anti-Delta. This is a past infection, 1% of 5% of all the infection versus active infections. And this is not considered. In many countries, you have people going to the blood bank for convenience, finding 2% of the prevalence of Delta is 2%. If they go to the hospital and liver disease, they find it 30% where Delta is still endemic. So where is the prevalence? But if you put things together, the prevalence, cumulative prevalence, are extremely confusing, essentially for two factors. A bias in the selection of patients based on what I told you, and the negligence of the effect of vaccination on the ongoing changes of hepatitis D in the world. This has to be considered. You cannot compare what was 15 years ago. I often see people putting together drug addicts 10 years ago and drug addicts 15 years ago and drug addicts now. Drug addicts now in high-income countries cannot have Delta because they were vaccinated at birth. Are you with me? So you put them together, you have a wrong number, have to distinguish now and then according to the impact of vaccination in that given country.
Thank you, Mario. We have a question for Raimundo, and then for Rainer. So we have many questions from the chat. So if you could respond to this question. So first, Raimundo, in your clinical practice, which patients you consider for pegylated interferon, and how do you treat them? It's 1 year. Do you have one stopping rule? Please, Raimundo.
Thank you, Tariq. In Brazil, most patients are young patients and not experienced before with interferon treatment. They are from Amazonia. Who, in general, we treat all of them with NUCs and interferon. This is in the Brazilian guideline. You can do this if you have more than 2,000 units of HDV viral load. But most patients have this profile. So in general, we treat both. It's a good question because we need to define subgroups of patients who, which are more easy to respond to interferon. And I think young patients respond better. And not experienced patients, I mean, naive patients respond better. So because of that, maybe we have a better response in non-controlled trials, a better response, virological response in Brazil than we has been reported in Europe and US.
Thank you, Raimundo. Rainer, there's a question from the chat. how do you explain the lack of clear dose response between 2 milligram, 5 milligram, 10 milligram of bulevirtide? You have done many trials. So why there's no difference between 2, 5, and 10?
Well, it's the mode of action, how bulevirtide actually interferes with NTCP. There are some differences. So there may be some patients showing a slightly higher response with the 10 milligram, but in the majority of patients with 2 milligram, you basically saturate enough receptors to block HBV or HBs antigen entry. However, I really have to highlight that there's a difference or a different dose required to block HBs antigen entry versus blocking the bile salt transporter function. So that's basically also explaining the trial result that, let's say, the more that there's no association between viral decline and bile salt increase because we have different doses required to block risk factors. But we also have to keep in mind that the viral decline is not only determined by blocking entry, but also by hepatocyte turnover. So if you have a different, let's say, disease activity, then you may have, let's say, more hepatocytes dying, which then should translate into a higher antiviral efficacy that you can measure in the blood. But to answer this one, so some patients may benefit from slightly higher doses, but for the majority of patients, 2 milligram are sufficient.
Heiner, a question to you, and then a question to Mario. For you, when you start bulevirtide, when do you consider to stop therapies? For which
at this stage, I do not stop. This is the short answer. I may stop in future when we have the data from the 301 trial, where 2 versus 3 years of treatment is currently being explored. So next year, there should be off-treatment data, and then a subgroup of patients may be identified where stopping may be possible. And we have the data from Pietro, the one patient that may have been cured, but we have the data from Vienna also, where the patient relapsed, and we have this data from 202, where the 6 patients maintained an off-treatment response after even only 24 weeks of treatment. So,
but at 1 year, there's around 20% in the fresh cohort who are non-responders. Do you consider to stop for non-responders?
For the non-responders, sorry. For the non-responders, the virological non-responder, I then first investigate for ALT levels. And there may be virological non-responder or not complete responder still benefiting from treatment, because, and that's very important to note, that patients may benefit even in the absence of a, let's say, sufficient virological response. So in the end, it's a case-to-case decision. If the patient has a sharp decline in ALT, then I do not stop.
Thank you very much. The last question for Mario. Mario, what's your opinion of this 2-log decrease during treatments? You know, the agency, the expert group propose this 2-log viral decrease. With your expertise, what is your opinion?
Well, you know that I'm skeptical about this. At this stage, however, I would recommend Heiner as well as Pietro to distinguish their series. Put aside those patients who have reached negative HDV RNA. These are a subgroup. And consider these subgroups, what they are, how they started, and then go on those who did not reach negative HDV RNA, which is the only hard point that I can conceive on. This is, in my opinion, the right way of presenting the data. Otherwise, you are inflating, in a sense, the results by a 2-log population where we don't know much, but it's not a hard response. Now that the results are coming, why not do this exercise so we know who are those who have responded fully and those who have had a 2-log decline? By the way, if you take off those who have responded fully, the curve of HDV RNA will increase, of course, because you're taking out of those who got 0. I would say that the results may be good, are good, but they should be expressed in a different way to be convinced, because the do log response is a partial response. It's not a response in any case. The only true response is a full response. Now there is enough material to consider this versus those who had not got a full response, and this is the most effective way, in my way, of reanalyze the data.
Thank you, Mario, for this good advice. I think we had excellent lectures by excellent experts. I would like to thank all the colleagues for their lectures, and thanks, Mario. Thanks, Heiner, Vasily, thanks, Raymond. And I wish all the attendees an excellent Paris meeting. Thank you, everyone.
Thank you.